Hello and welcome. I'm Gerald Major from the Canadian Spondylitis Association, and I am extremely privileged to be sitting here with Dr. Walter Maksymowych, who I'm meeting today for the first time, but I've spoken to many times. And just for those out there, I mean, the amount of work that you've done in the spondyloarthritis community is fantastic, and we all appreciate that. So thank you. How about we just get into introduction of yourself and
Sure.
How you're involved in rheumatology.
Yes, thank you very much. So it's a great pleasure to have this opportunity to speak to the community. So I'm a rheumatologist at the University of Alberta, and I'm also a medical scientist, and I have an academic research organization that's named Canadian Research and Education in Arthritis. And through those various affiliations, I've been involved extensively in arthritis research, particularly inflammatory types of arthritis, and particularly inflammatory arthritis affecting the spine. I've been involved in all sorts of clinical trials, spent a lot of time assessing imaging as a way of getting more detailed information from patients with arthritis. And also a great deal of time expended in education activities, not just in Canada but across the world, to try and keep people appraised of recent advances in the field.
So what are you most looking forward to in your time here at the CRA?
Well, I'm interested to hear people's views about precision medicine and where they think it's going to lead us in the next little while. It's a very, very rapidly moving field with new technologies being developed, and we're only just starting to understand how we might be able to use some of this technology. And then when you add to that some of the potential advantages of artificial intelligence and the ways that artificial intelligence is being proposed to help physicians to understand patients' problems and to provide better care, I think there's a huge amount of information to absorb, and it's really very exciting. I wish I was 20 years younger.
Right. I mean, well, that since you mentioned that, I mean, I'm a pre-biologic patient, right? So I mean, I was showing symptoms in '86, which was 16, 17 years before biologics. And for me, when I look at the progression of medicine and treatments over the years, and now to talk about precision medicine, I mean, it's very, I wish I was also 20 years younger because I'd probably be doing a lot better and a lot less surgeries than I have right now. You've taken a particular stance on for the Great Debate. So tell us about the Great Debate and your stance on it, and
yes,
and we'll go
okay.
from there.
So I've been asked to present arguments for the motion that precision medicine is an important way forward. And perhaps I've also been asked to argue the view that precision medicine will provide tools that might even reduce the need for rheumatologists, which I think is a somewhat provocative stance to take. But perhaps another way to look at the argument is that I feel very strongly that the tools will, at the very least, enhance what rheumatologists are capable of, what they're going to be able to do in the future. So we do have some very important unmet needs. You mentioned that you've received some very good therapies and that you're feeling well. But there's still challenges. Our therapies are good, but our way of targeting those therapies to the right patient are not very good. And we still rely on a lot of guesswork. We have an awful lot of patients in the community with joint pains, and then finding the patient who actually turns out to have rheumatoid arthritis or some other type of arthritis is really quite challenging. And we can't have every single one of these patients going to see an arthritis specialist. There's not enough arthritis specialists to go around. So we have to find point-of-care testing kits and the ability to identify patients in the community. That's the first thing. The second sort of major unmet need is that we are going to need precision tools to understand which patients are destined to develop more severe disease. So we have 100 patients in front of us, let's say, and we know that around 60 to 70% are going to respond well to fairly simple therapies. Disease-modifying therapies, a common one being methotrexate. But we can't identify the 30 to 40% who aren't going to do well. And, you know, you have to wait a fair bit before methotrexate exerts its maximum effects. That's 4 to 6 months. And you can have a fair bit of damage in your joints in that period of time. So we would ideally like to identify the people likely to have a more severe disease course as soon as possible. So give them the appropriate treatment right from the start. And then even amongst the very, very good biological therapies that have really transformed people's lives, there are differences between them. And we don't know which ones go with which patients. Some patients react and develop side effects, and others, for reasons that are totally unexplainable, those patients do not respond to that particular biologic, and we have to switch to another. And every time you switch, well, of course, healthcare utilization costs go up because that patient is not feeling well, is not doing well, is going to see the primary care physician and the physiotherapist and the pharmacist, trying all kinds of additional things to try to get better. So precision tools are essential. I mean, there's an absolute unmet need. And with the mass of data that's being generated as we provide and enter data into electronic medical records, that kind of information as well is really helping us to understand which patients might be the ones that respond best. But we're also going to need those very sophisticated tools, you know, the ones that assess genetics and the ones that assess the proteins, the fingerprint technologies in the blood. We're going to need combinations of those tests to identify patients at risk of arthritis, patients who are going to respond well to simple therapies, and then patients who are going to require more intensive therapy from day one.
As you're saying that, I mean, from a patient perspective, I mean, it sounds fantastic. I mean, this is kind of groundbreaking stuff. I can't think of a better person to be trying to wrap their head around that. You mentioned a little bit about the waste, and I look at kind of from a mental health perspective, I look at how much trial and error and how far behind they are on medications and getting it right, and then I look to where we are with rheumatology here, and there's a fair amount of waste to the healthcare system and pharmacare in Canada by all these different, you know, trial and error type stuff. So,
yes. But there is progress that's been made in other areas. For example, a lot of data has been generated around optimal ways to manage patients who develop heart failure, right, and what types of patients should receive optimal interventions. We're seeing remarkable progress, particularly with the use of precision tools in the treatment of different types of cancer. We're seeing remarkable advances in using combinations of precision tools to screen for colon cancer. And these are very, very recent innovations. So the FDA just recently approved some of these tools for screening colon cancer. And just very recently as well, there is a specific genetic, if you like, fingerprint that identifies a specific type of cancer. It doesn't matter where that cancer is, and where it spread to. But this particular treatment will target those patients who have that specific type of cancer. So what we're starting to see is that we're starting to see these very targeted therapies towards those cancers which have got these very specific genetic abnormalities. So cancers can be identified by the way that they grow and develop and the genetic abnormalities that they acquire. And certain types of cancers, and there can be cancers, for example, in the colon or in the ovary or in the breast. So they share that genetic abnormality. And so the treatment that targets that genetic abnormality is going to work for all of those cancers, irrespective of where they are. Wow. So this is the sort of direction and the sort of advances in treatment that are really moving us forward. And it's really on the last year or two that we've got to that point. So the best is yet to come.
How, you mentioned a little bit about comorbidities, and what I found from our community and speaking with others living with specifically spondyloarthritis is that before too long the conversation goes to comorbidities. So how do comorbidities within the realm of spondyloarthritis, and I mean, does it complicate things from a precision medicine perspective, do you find?
It can certainly complicate the interpretation of biomarkers, for example, precision tools, yes, because there are other diseases that can influence some of these biomarker tools. But the extent of technological innovation and using combinations of biomarkers together is still going to give you a more precise fingerprint. Right. See, the way that we have thought of biomarkers until very recently is that, you know, we kind of measure one thing, one protein. You know, if you have rheumatoid arthritis, you measure the rheumatoid factor test. And we know that's a problem because there will be patients, or people rather, who have a positive rheumatoid factor but don't have rheumatoid arthritis and will never get rheumatoid arthritis. And so we've known for a long time how crude a test the rheumatoid factor test is, but the technologies that are being developed now and tested in patients now are much more sophisticated, and they include combinations of biomarkers that are going to be much, much more specific for specific types of arthritis.
Do we have any questions from the audience at this point?
Do you have any lifestyle tips for people living with spondyloarthritis?
Yes. One of the important things, several important things that we teach patients is that they have to maintain good core muscle strength. And what we often find is that patients with spondyloarthritis, because they have pain, become physically deconditioned. Clearly, a patient in pain is quite disinclined to exercise. And particularly when those patients start on treatment and have a good treatment response, they're sometimes a little disappointed with the level of the response and think that's because they're resistant to the therapeutic. And it isn't that the case. The reason is that you really have to maintain good core muscle strength. And so it's very important that the major muscle groups are strong, and you do not want to add to back problems. And I think that applies to all types of arthritis. Once the inflammation resolves, you've got to start exercising. You've got to make your tendons and your joint capsule stronger. You've got to enhance joint stability, and you've got to make sure you don't develop problems like slip discs in your spine because you've become physically deconditioned, and so you have poor muscle strength. People often ask about diet, but we really haven't identified any consistent dietary factors that make a difference. Vitamin D is a factor that we think is important simply because we live in Canada. Now, we've got to maintain good bone strength. We don't want to add fractures to our problems, so we don't want patients developing fractures, for example, with minimal injuries and falls. So that's something that we recommend as routine intake of 1,000 units a day. And then relaxation and stress alleviation techniques that can be taught by physiotherapists, for instance, in addition to the strengthening techniques that I discussed, and stretching and appropriate posture are very important. It's mainly around physical modalities of treatment, and of course, something that's very important is maintaining ideal body weight.
And for people who work at an office job, do you have any exercise that you could demonstrate? You're in a chair right now.
Yes.
For them, that they could build their muscle strength or core strength?
So that is a challenge that faces us all, or many of us, and I tend to take advantage of the local stairs, and I go up and down stairs where possible. I think a pelvic tilt is something that could be done easily in the office. It's important to take frequent breaks to stretch, and a pelvic tilt is really quite easy to do for those of you who might be unfamiliar with that. You lie down with your knees bent and you put your hand behind your back, and what you try and do is you try and squeeze your abdominal muscles flat so that you're squeezing down on your hand behind your back as if you're trying to make a pancake out of it. And that pelvic tilt can be very good at strengthening core. Then you can do a few more exercises when you go home. It's often very helpful for patients, if possible, to at least get some initial advice from a personal trainer and to be shown, or a physiotherapist, and to be shown how to do some things both in a home environment, a work environment, and maybe even go to a gym and start doing some gradual exercises aimed at maintaining strength and aerobic conditioning.
And an audience wants to know, why does it take so long to get diagnosed with ankylosing spondylitis?
Well, that is indeed a problem, and that's because we lack those precision tools. We don't have a simple, easy test that is going to detect that early inflammation that develops in the sacroiliac joint. So the best way that we can do it right now is using an MRI. And that, of course, is difficult in some parts of the world. We should have better access to MRI in Canada. I think our society really should have much better access than we do to MR imaging, and particularly because there is evidence emerging that the sooner you treat, the better the outcome. I mean, it's unacceptable for patients to have to wait 6-9 months to get an MRI, as they frequently have to, when we know that there are highly effective therapies that would alleviate the pain and get patients back to work and social participation, leisure activities, and so on. It's absolutely unacceptable, and we see that in some provinces around Canada.
That is all for the questions.
So, I mean, a few things before we wrap up. I think there's been a shift a little bit in exercise, where it seems that, I mean, this is one way that I get around it, is I try to be active every day. So I wear a watch and I try to track my things, and I try, so not necessarily do I need to be in a gym. So in the summertime when it's nice out, if I can get to the pool, then I'll do that. And if we're at an amusement park and there's a lot of walking around, then I'll count that. And it seems to be a better way to, I mean, keeping things consistent with gym and diet, and they all end up intertwined, because if you're not exercising, you kind of maybe not hungry.
Yes,
and that's
indeed.
the whole
Yeah.
circuit. So That's the way that kind of I try to express it to the arthritis community. But one thing I want your thoughts on before that, and for me personally ends up being an issue, is chronic fatigue. A lot of people talk about pain, and the way I process it is that pain will be there and you can work through pain. What I have really hard time with is the fatigue element.
Yes, and that is indeed a common problem. So I think what you've alluded to that is very important for people when they're trying to stay active is to try and have some kind of a target. And you mentioned that you wear a watch that keeps track of your activity, and I think that's one way that people can aim for a target. I know that when I exercise, I've got a certain number of repetitions that I'm going to do with a X amount of weight for the different areas that I'm exercising. So I think it is important to set targets. That's just the way we're wired. And I think it is important for us to aim at targets and try and work to those targets, come what may. And then the issue of fatigue is certainly very important, and it's a difficult one to deal with because there are so many different factors that influence fatigue. So what we try and do as physicians is identify factors driving fatigue that are readily reversible. So if disease is active, we know that can make a patient feel fatigued. So one of the questions I'm certainly keen to address when I'm evaluating the patient is, am I confident that we've now reached a very low level of disease activity with all the testing that I'm doing? And then the second question is, well, is there some other factor? Have you had a recent general physical, general evaluation for your family physician? Could there be a thyroid problem, for instance? So that is also important because we can't lose sight of the fact that patients with arthritis do develop other problems.
Right.
For example, a higher risk of autoimmune thyroid disease. And then I think the third factor for a lot of people is this physical deconditioning. And it's an old-fashioned term, but I still like it, stamina.
Right.
It's important to build stamina. The only way you can really do that is if you do some aerobic exercise. And if you do some aerobic exercise, you're going to build stamina and you're going to sleep better. Right. Sleep is very much part and parcel of this. And a lot of people are simply not getting good quality sleep. What's driving that could be a lot of different things, stress, it could be a physical issue, but that's something that really needs to be discussed also with the family physician, the rheumatologist, and reversible factors need to be identified.
Well, unless there's anything else, I'd like to thank you so much for all of your insight. Meeting you in person is something that I appreciate and value very much. And I can't think of better people really to be looking after our community. So thanks for what you've done and what you'll continue to do.
Thank you very much indeed. It's a pleasure and a privilege for me.